Assalamualaikum warahmatullahi ta'ala wabarakatuh. So today we're going to tackle about the intraoperative nursing management. So these are the learning objective of this topic. So we have to describe the interdisciplinary approach to the care of the patient during the surgery, and also describe the principles of surgical asepsis. Describe the roles of the surgical team members during the intraoperative phase of care. Then we have to identify the adverse effect of surgery and anesthesia, and identify the surgical risk factors related to the age-specific populations and nursing interventions to reduce those risks, and compare the various types of anesthesia with regard to uses, advantages, disadvantages, and the nursing responsibilities, and also the identify the use of the nursing process for optimizing patient outcomes during the intraoperative period. So the intraoperative phase. So this is involved the surgery itself. So the intraoperative nurse cares for the patients from the time the patient is moved onto the OR bed or operation room bed. So until the patient is transferred to the care of the recovery room nurse or the post-anesthesia care unit. So during this phase, the patients will be prep and typically given some form of anesthesia, either general anesthesia for complete unconsciousness, the local anesthesia to prevent pain while awake, or the regional anesthesia such as with the spinal or the epidural block. Surgery team include the patient, the nurse, the circulating nurse, the scrub roll, the surgeon, the registered nurse, first assistant or the RNFA, and the anesthesiologist or anesthetist. So the surgical team must work together to deliver safe and effective care to the patients in the intraoperative phase. So in this phase, the scope of nursing activities include providing for the patient's safety, maintaining an aseptic environment, ensuring proper functions of equipment, providing the surgeon with specific instrument and supplies for the surgical field, and completing appropriate documentations. So the patient. So as the patient enters to the OR or the operating room, he or she may feel either relaxed and prepared, or fearful and highly stressed. So these feelings depend on to a large extent on the amount and timing of perioperative sedations and the patient's level of fear and anxiety. So like fears about loss of control, the unknown, pain, death, changes in body structure, or the function and disruptions of lifestyle, all may contribute to generalized anxiety. So these fears can increase the amount of anesthetic needed, so the level of postoperative pain, and overall the recovery time. So the patient also subject to several risks like infection, failure of the surgery to relieve symptoms, temporary or permanent complications related to the procedure or the anesthetic, and death are uncommon but potential outcomes of the surgical experience. So these are the potential adverse effects of surgery and anesthesia. So anesthesia and surgery disrupt all the major body systems. So although most patients can compensate for surgical trauma and the effects of anesthesia, all patients are at risk during this operative procedure. So these are the risks include the following. So first, the allergic reaction. So the cardiac dysrhythmia from electrolyte imbalance or the adverse effect of the anesthetic agents. So the myocardial depression, the bradycardia, and the circulatory collapse. So the central nervous system, agitation, seizures, and respiratory arrest. So over sedations and under sedation, the agitations or disorientation, especially in elderly patients. So hypoxemia or hypercarbia from hypoventilations and inadequate respiratory support during the anesthesia. So the laryngeal trauma, the oral trauma, and also broken teeth from difficult intubations, the hypothermia from cool operating room temperatures, like exposure of body cavities, and impaired thermoregulation secondary to anesthetic agents, the hypotensions from blood loss or the adverse effect of anesthesia, and also the infection, thrombosis from compressions of blood vessels or stasis, and the malignant hyperthermia secondary to adverse effect of the anesthesia. So, and the nerve damage, skin breakdown from prolonged or inappropriate positioning, electrical shock or burns, the laser burns, and the drug toxicity, faulty equipment, and the human error. So the elderly patients needs a fewer and a smaller amount of anesthetic agents to produce the anesthesia. Anesthetic agent to produce anesthesia and eliminates the anesthetic agents over a longer period of time compared with the younger patient. So, why elderly patients face higher risk from anesthesia and surgery than the younger adults patients do? So, it because statistically, perioperative risk increases with each decade after 60 years of age, often because of the increased incidence of the coexisting disease. So, these are the other factors that affect the elderly surgical patients in the intraoperative period include the following. Impaired the ability to increase metabolic rate and impaired thermoregulatory mechanism increases susceptibility to hypothermia. Number 2, the bone loss like 20% in women and 12% in men necessitates careful manipulations and positioning during surgery. And number 3 is to reduce the ability to adjust rapidly to emotional and physical stress influences surgical outcomes, um, and the requires meticulous observations of the vital functions. So, as expected, mortality is higher with emergency surgery, commonly required for the traumatic injuries, than with the elective surgery. So, making continuous and careful monitoring and prompt interventions especially important for older surgical patients. So, the nursing care. So, these are throughout the surgery. So, the nursing responsibilities include the following. So, like providing for the patient's safety and well-being of the patients, coordinating the OR personnel. So, maintaining aseptic movement environment, performing the scrub and circulating activities. So, the care begun by preoperative nurses is continued by the intraoperative nursing staff who provide the patients with the informations and reassurance. So, and also maintaining surgical standards of care and identifying the minimizing risks and complications. So, the circulating nurse. So, the circulating nurse, this is also known as or the circulator. So, is preferably RN or the registered nurse. so who coordinates and documents the patient's care in the operating room. So he or she manages the OR and protects the patient's safety and health. So by monitoring the activities of the surgical team, checking the OR conditions, and continually assessing the patient's first signs and injury and implementing the appropriate interventions. So the main responsibilities include so verifying the consent, coordinating the team, so ensuring cleanliness, the proper temperature, humidity, the lighting, the safe functioning of equipment, and the availability of supplies and materials. So monitors aseptic practices to avoid breaks in technique while coordinating the movement of related personnel like medical, x-ray, and laboratory, as well as implementing fire safety precautions. So every member of the surgical team verifies the patient's name, procedure, and surgical site using the objective documentation and data before beginning the surgery, as mandated by the Joint Commissions on Accreditations of Healthcare Organizations. So the scrub role. The scrub role. So the activities of the scrub role include performing a surgical hand scrub. So the RN, or the licensed practical nurse or surgical technologist, who scrubs and dons the sterile surgical attire, prepare the instrument and the supplies, and also the hands instruments to the surgeon during the procedure. So these are the activities of the scrub role. So performing a surgical hand scrub, setting up the sterile tables, preparing the sutures, ligatures, and special equipment, example laparoscopy, laparoscope, the procedure by anticipating the instrument and supplies that will be required, such as sponges, drains, and other equipments. So as the surgical incisions is closed, the scrub person and the circulator counts all the needles, the sponges, and instrument to be sure they are accounted for and not retained as a foreign body in the patient. So standard calls for all these sponges to be visible on X-ray and for the sponge count to take place at the beginning of the surgery and twice at the end. So tissue specimens obtained during the surgery are labeled by the scrub person, sent to the laboratory by the circulator or the circulating nurse. So the surgeon. So the surgeon, they are the ones who perform the surgical procedures and heads of the surgical team. It's like he or she is a licensed physicians or osteopath, oral surgeons, podiatrists, who is specially trained and qualified. So number 6, so the registered nurse first assistance. So the RNFA is another member of the OR team. So although the scope of practice of the RNFA depends on each state's Nurse Practice Act. So the RNFA practices under the direct supervisions of this surgeon. So the RNFA responsibilities may include handling the tissue, providing exposure at the operative field, suturing, and maintaining the hemostasis. So the role of this registered nurse first assistant is it requires a thorough understanding of anatomy and physiology, like tissue handling and the principles of the surgical asepsis. So the RNFA must be aware of the objectives of the surgery, must have the knowledge and the ability to anticipate needs and to work as a skilled member of the team, and must be able to handle any emergency situations in the OR.
So number 7, the anesthesiologists and the anesthetists. So anesthesiologist is a doctor that responsible for administering anesthetics. So assess the patient before surgery, and then select the anesthesia, administer it, and intubated the patients. So they are the one that manage any technical problem related to the administrations of anesthetics. And also they are the ones to supervise the patient's condition throughout the surgery. So these are the American Society of Anesthesiologists Physical Status Classification System. So if a patient has a qualifications of P1, P2, P3, or P4, he or she has a systematic disease that may or may not be related to the cause of surgery. So if a patient with the classifications of P1, P2, or P3, P4, or P5, it requires emergency surgery. And E is added to the physical status designation. So for example is P1E or P2E. So this is requires as emergency surgery. So P6 refers to a patient who is brain dead and is undergoing surgery as an organ donor. So during the surgery, the anesthesiologist or anesthetist monitors the following, like patient's blood pressure, pulse, respirations, as well as the cardiogram, blood oxygen saturation level, tidal volume, blood gas levels, blood pH, alveolar gas concentrations, and the body temperature.
So this video, I'm going to report my topic about the surgical environment. So the surgical is known for its stark appearance in cold temperature, and surgical suit behind double doors and access limited authorized personnel. So the purpose of clean, safe, effective surgical environments is to reduce the risk contamination by entering the patient operative site and causing infections. So they have a policy government. So environment address such issue as the health of the staff and cleanliness of the rooms and the sterile of equipment and surface. So the surgical area is divided into 3. So number 1, unrestricted zone, which is where street clothes are allowed. Number 2, semi-unrestricted zone, where its attire consists of scrub, clothes, and caps. Number 2, restricted zone, where clothes, shoes, cover, and caps, and masks for the wound. So, for the principle of surgical asepsis prevents the contaminations of surgical wounds. So, all surgical asepsis supplies, which is needles, suturers, dressing, gloves, and cover, and solution. So, how do you maintain the surgical asepsis? To maintain the surgical asepsis is a safe space or margin of safety between sterile and non-sterile. So, maintain environmental controls. So in addition to the protocol described previously, surgical asepsis required a meticulous cleaning and maintaining of the OR environment. So we have sterile equipment, and all equipment that comes into direct the patient must be sterile. So proceeding to the basic guidelines for maintaining surgical asepsis, we have all materials in contact with surgical wound or use within the sterile field must be sterile. Gowns for the surgical team are considered sterile, and sterile drapes are used to create sterile fields. So here's the Hazard associated with the surgical environment, safety issue in the OR. So, itong mga hazard kailangan natin iwasan kasi nakakapekto sa ating pasyente. So, laser risk effect can range from mild skin versus to invisible injury to the skin and the eye. So, exposure to the blood and blood fluids can cause HIV. So, latex allergy, your body mistake latex for harmful substance cause itches skin in hands. So, surgical experience, during the surgical procedure, the patient will need sedations or anesthesia. So, this hazard associated, kailangan before go to OR, kailangan i-review ang record of the patient para iwas ang mga hazard na to.
Hello guys, I'm Miss Anabit Pamate. So now I'm going to tackle about the types of anesthesia and sedation. Anesthesia today is very safe. This is true nowadays, but was not always the case. Dr. Trianos emphasizes that the anesthesia is safer today because of the advanced technology and medication. It is estimated that the number of anesthesia-related deaths is as low as 1 in 200,000 to 300,000 cases. Dr. Trianos says in the 1960s and 1970s, it was not uncommon to have death related to anesthesia is every 1 in 100,000 or 200,000 patients, he says nowadays. He says nowadays, like in 1 in 200,000 or 300 patients, it is very rare. For the patient, the anesthesia experience consists of having an IV line inserted if it was not inserted earlier, receiving a sedating agent prior to induction with an anesthetic agent, losing consciousness, being intubated if indicated, and then receiving a combination of anesthetic agents. Typically, the experience is a smooth one, and the patient has no recall of the events. Before this surgery, you will get anesthesia through an IV line that goes into a vein in your arm or hand. You might also breathe in gas through a mask. You should fall asleep within a couple minutes. So, the main types of anesthesia are general anesthesia, regional anesthesia, moderate sedation, monitored anesthesia care, and the local anesthesia. So, the general anesthesia is a state of narcotic or the severe central nervous system depression produced by pharmacologic agents. Analgesia, relaxation, and reflex loss. Patients under general anesthesia are not arousable, not even to painful stimuli. They lost the ability to maintain ventilatory function and require assistance in maintaining patient airway. So, the cardiovascular function may be impaired as well. And the general anesthesia is medicine you get before some types of surgery to make you sleep and prevent you from feeling pain. General anesthesia also used for major operations such as knee replacement or open heart surgery and cause you to lose consciousness. General anesthesia consists of 4 stages, each associated with specific clinical manifestation. Rock since 2003. Stage 1, beginning anesthesia. Stage 2, excitement. Stage 3, surgical anesthesia. Stage 4, medullary depression. So, the stage 1 or beginning anesthesia or the induction. The early stage lasts from when you first take the medication until you go to sleep. You are calm but able to talk for a while. Your breathing is slow but regular and you lose the ability to feel pain. And this is stage 2, excitement. The second stage can be dangerous, so the anesthesiologist will want to get you through it as quickly as possible. You can have uncontrolled movements, fast heartbeat, and irregular breathing, you might vomit, which could you make choke or stop breathing. The stage 3 surgical anesthesia. Surgery can take place. Your eyes stop moving, your muscles completely relax, and you may stop breathing without the help of machines. The anesthesiologist will keep you until the procedure is over. Stage 4 medullary depression, or it's also known as the overdose. If you get too much anesthesia, your brain will stop telling your heart and lungs to work. It is rare with modern technology, but it can be fatal. When opioid agents or the narcotics and neuromuscular blockers relaxants are administered, several of these stages are absent. During smooth administration of an anesthetic, there is no sharp division between stages 1, 2, and 3, and there is no stage 4. Anesthetic agents used in general anesthesia are inhaled or administered by IV. Anesthesia procedures. Anesthesia because they are delivered to the brain at a high partial pressure that enables them to cross the blood-brain barrier. Relatively large amounts of anesthetic must be administered during induction and the early maintenance phases because the anesthetic is recirculated and deposited the body tissues. As this site becomes saturated, smaller amount of the anesthetic agent are required to maintain anesthesia because equilibrium has been achieved between brain, blood, and other tissues. Any conditions that diminishes peripheral blood flow, such as vasoconstriction or shock, may reduce the amount of anesthetic required. Conversely, when peripheral blood flow is unusually high, as in a muscular active or apprehensive patient, induction is slower and greater quantities of anesthetic are required because the brain receives a smaller quantity of anesthetic. So the inhalation. Inhaled anesthetic agent includes volatile liquid agents and gases. Gas anesthetics are administered by inhalation and are always combined with oxygen. Nitrous oxide is the most commonly used gas anesthetic agent when inhaled. The anesthetic enters the blood through the pulmonary capillaries and action on cerebral centers to produce loss of consciousness and sensation. When anesthetic administration is discontinued, so the vapor or gas is eliminated through the lungs. The vapor from inhalation anesthetics can be administered to the patient by several methods. The inhalation anesthetic may be administered through an LMA, flexible time, with an inflatable silicone ring, cuff that can be inserted into the larynx. The endotracheal technique for administering anesthetics consists of introducing a soft rubber or plastic endotracheal tube into trachea, usually by means of laryngoscope. The endotracheal tube may be inserted through either the nose, mouth. When in the place, the tube seals off the lungs from the esophagus so that if the patient vomits, stomach contents do not enter lungs. Insert inhalation anesthetic agents. Anesthetic delivery methods like inhalation anesthetics such as nitrous oxide, halothane, isoflurans, desiflurans, sevoflurans, most commonly used agents in practice today. These are used for induction and maintenance of general anesthesia in the operating room.
Hi guys, so next is the intravenous administration. So when we say intravenous, it means within a vein. So most often it refers to giving medicine or fluids by a needle or tube that is inserted into the vein. So this general anesthesia can also be produced by an
intravenous administrations of various substances such as barbiturates, non-barbiturates, dissociative agent, and opioid agent. So this barbiturate and non-barbiturate is both a CNS depressant, which is used to treat insomnia, headache, and seizure. The dissociative agent is usually used in surgery as for analgesia or pain relief. Next one is the opioid agent. Opioid agent is used in the management of pain also in surgery. So there are some opioid analgesia such as morphine sulfate. The uses of it be as a premedication, advantage, good in cardiovascular stability, and the disadvantage is has experienced nausea, vomiting, and histamine release. And the other one is the alpenta. It is used as a surgical analgesia for an ambulatory patient. The advantage of this is used as Hox infusion, and there is no disadvantage in this drug. And the other one is the fentanyl. This is used as a surgical analgesia, and it is good for cardiovascular stability. There are no disadvantages. Disadvantage of this. Next is the advantages of intravenous anesthesia, such as the thiopental and pentotal. This is a powerful respiratory depressant effect. So this intravenous anesthesia must be administered by skilled anesthesiologists or anesthetists, and only when some method of oxygenation is administered is available in case of difficulty in sneezing, coughing, and nasopharyngospasm. So this intravenous anesthesia, dapat yung mga skilled anesthesiologists, nurses, ang mag-a-administer nito to the patient para masigurado na incorrect dosage talaga. So, if an IV insertion, if there's any problem occur like difficulty in coughing, sneezing, breathing, that's the time you need to provide oxygenation for the patients. Next is the neuromuscular blocker or relaxants. So this blocks the transmissions of the nerve impulses. So this neuromuscular blocker are used to relax muscles in abdominal and thoracic surgery, and also help relaxes eye muscles and a certain type of surgery. So there are some medicine for muscle relaxant. Example like metocurine. It uses as a maintenance of relaxation, and the advantage of this is a good cardiovascular stability, and the disadvantage, you will have the slight histamine release. Next is the regional anesthesia. So this regional anesthesia is a form of local anesthesia in which an anesthetic agent is injected around the nerve so that the area supplied by these nerves is anesthetized. So this regional anesthesia commonly ginagamit sa mild surgery like cysts or mga circumcised, magtuli, ganyan. So the effect depends on the type of nerves involved in the local anesthetic. So yung effect ng anesthesia, nakadepende siya sa nerve, ready ba yung motor or sympathetic nerve. Yan. An anesthetic cannot be regarded until the three systems, motor, sensor, and automatic, are no longer affected. So the patients receiving this regional anesthesia, the patients who receive this regional anesthesia usually awake, but they has this hallucination, yung iba't ibang pumasok sa utak nila, ganyan. So the nurse must avoid the care. So the nurse must avoid careless conversation, unnecessary noise, and unpleasant odor. This may contribute to a negative response to the surgical experience of the patients. Kaya dapat i-avoid yung mga careless conversation. Kung example, mag-hallucinate sila, ganyan, support mo lang kung ano yung sa ano nila sa outer space. Kaya wag mo i-contradict o ganyan sa ano. Dapat sakayan mo lang para di siya maging negative response doon sa surgical experience. Next is epidural anesthesia. So the next is the epidural anesthesia. So this commonly used condition block achieved by injecting anesthetic into the epidural space surround the durometer of the spinal cord. So usually this epidural anesthesia ginagamit siya sa mga major surgery like kidney, liver, and heart surgery, like that. So this epidural anesthesia blocks the sensory, motor, and automatic functions of the nervous system. So this epidural anesthesia dosage higher compared to the other anesthesia because it does not make directly contact to the spinal cord. Kaya it required a high dosage para ma-move talaga yung So the advantage of epidural anesthesia is you have absence of headache, help muscle relax, and the disadvantage of this epidural anesthesia is if an inadvertent puncture on the dura occurs during the epidural anesthesia, an anesthetic travels to the head. So during this epidural anesthesia, if there's an accident puncture, so the anesthesia might travel to your head, and this may cause the high spinal anesthesia can result to the severe hypotension, where the blood pressure drop below the normal range. So treatment of this complication includes airway supports, IV fluids, and the use of vasopressor. Vasopressor is some drug agent which causes constrictions of the blood vessel.
So my topic for today is spinal anesthesia. Spinal anesthesia is an extensive conduction nerve block that is produced when a local anesthetic is introduced into the subarachnoid space at the lumbar level, usually between L4 and L5. So L stands for lumbar spine, the interspace of L4 and L5, using a toy needle. The toy needle is a long needle. The spread of anesthetic agent and the level of anesthesia depends on the amount of fluid injected, the speed with it is injected, the positioning of the patient after the injection, the specific gravity of the agent. A few minutes after induction of a spinal anesthetic, anesthesia and paralysis affect the toes and perineum and gradually the legs and abdomen. These are the side effects of spinal anesthesia. Nausea, vomiting, and pain may occur during surgery. When spinal anesthesia is used, as a rule, this reaction results from manipulation of various structures, particularly those with the abdominal cavity. The simultaneous IV Administration of a weak solution of thiopental and inhalation of nitrous oxide may prevent such reactions. Headache may be an after effect of spinal anesthesia, but there's an IV medication must be injected if you experience headache. Several factors are related to the incidence of headache: the size of spinal needle used, the leakage of fluid from the subarachnoid space through the puncture site, and the patient hydration status. Measures that increase cerebrospinal pressure are helpful in relieving headache. These include maintaining a quiet environment, keeping the patient lying flat, and keeping the patient well hydrated. So the patient must be hydrated. As you can see the figure 19-2. Spinal anesthesia involves injection of medication into the sac of fluids that surround your spinal cord to reach the fluid sac. The anesthesia will pass the needle through spinal ligaments and dura and protective membrane around the spinal cord. Spinal anesthesia begins working almost immediately after injection completed. So the spinal anesthesia will work immediately after the injection, not like epidural anesthesia. Example. So as you can see, the good example for spinal anesthesia is for the pregnant woman. The pregnant woman, if they want to stay awake during the delivery of the baby. So my next topic is local conduction block. Local conduction block. Examples of common local conduction blocks are brachial plexus block, which produces anesthesia of the arm; upper limb block, nerve distribution and spinal root destruction. Blocks of the upper limb can be done by interscalene approach. Interscalene approach, which is actually in the neck. Supraclavicular approach above the clavicle, and the intraclavicular approach, which is in below from the clavicle. Infraclavicular approach, which is below from the clavicle, and last one is axillary approach through the armpit. The next is infraclavicular approach. It is good block for elbow, arm, and hand surgery, and while the supraclavicular approach for elbow and forearm and hand surgery. The next one is interscalene. Interscalene block in the neck at the level OCX for shoulder, arm, and elbow surgery, but it is a little bit risky because it is in the neck. It might be block the breathing. The next one is the next block, conduction block, is paravertebral anesthesia, which produces anesthesia of the nerves supplying the chest, abdominal wall, and extremities. Paravertebral block is a technique where a local anesthetic is injected into the space adjacent to the vertebrae to block the spinal nerves as they emerge from the intervertebral foramen. Here, the spinal nerves are devoid of covering fascia, making them sensitive to the action of local anesthetics. The next one is transsacral or caudal block, which produces anesthesia of the perineum and occasionally and lower abdomen. Transsacral epidural block provides anesthesia of the rectal, anal, or urethral region and has been performed through the dorsal sacral foramen.
Good morning. My name is Fatima Hayrin Sarapudin Musad. So, my topic for today is about nursing process. So, nursing process, during the nursing surgery the perioperative nursing data set or PNDS is a helpful model used by nurses in the intraoperative phase of care. Phenomena of concern to intraoperative nurses are nursing diagnosis, interventions, and outcomes that surgical patients and their families experience. Additional areas of concern include collaborative problems and expected goals. So, for the assessment, nursing assessment of the intraoperative patient involves obtaining data from the patient and the patient's record to identify variables that can affect and serve as guidelines for developing an individualized plan of patient care. So, the intraoperative nurses uses the focused preoperative nursing assessment documented on the patient record. This includes assessment of physiologic status, example, health illness level of consciousness. So for the psychological status, example, is the anxiety level, verbal communication problems, coping mechanisms. So for the physical status, we have surgical site, skin condition, and effectiveness of preparation, immobile joints, and ethical concerns. So for the planning and goals, we have goals for care of the patient during surgery include reducing anxiety, preventing positioning injuries, maintaining safety, maintaining the patient's dignity, and avoiding complications. For the nursing interventions, so for the prevention and intraoperative positioning injury. So the patient's position on the operating table depends on the surgical procedure rather to be performed as well as on his or her physical condition. The potential for transient discomfort or even permanent injury is clear because many positions are awkward. Hyperextending joints, compressing arteries, or pressing on nerves and bony prominences usually results in discomfort simply because position must be sustained for a long period. Factors to be considered include the following. Nerves must be protected from the undue pressure. Improper positioning of the arms, hands, legs, and feet may cause serious injury or paralysis. Shoulder braces must be well padded to prevent irreplaceable nerve injury, especially when the Trendelenburg position is necessary. So for the precautions, patient safety must be observed, particularly with thin, elderly, or obese patients or those with physical deformity. The patient needs gentle restraints before induction in case of excitement. So for the Trendelenburg position, usually used for surgery on the lower abdomen and pelvis to obtain good exposure by displacing the intestines into the upper abdomen, in the position. So the head and the body are lowered. The patient is held in position by padded shoulder braces. So for the lithotomy position is used for nearly all perineal, rectal, and vaginal surgical procedures. The patient is positioned on the back with the legs and thigh flexed. The position is maintained by placing the feet in stirrups.